within the hundreds of millions of alveolar capillary units. Diffusion barrier is seldom a major cause of a low PaO2. Review the O2 dissociation curve shown on slide 30. X represents the second set of blood gases for a patient who presented to the ER with headache and dyspnea. His first blood gases showed a PaO2 of 80 millimeters of mercury, a PaCO2 of 38 millimeters of mercury, and a pH of 7.43. Oxygen saturation on this first set was calculated from the O2 dissociation curve at 97%, and oxygenation was judged to be normal. He was sent out of the ER and returned in a few hours with mental confusion. This time, both the oxygen saturation and the carboxyhemoglobin were measured. PaO2 was 79 millimeters of mercury. PaCO2 was 31 millimeters of mercury with a pH of 7.36. However, the oxygen saturation was 53% and the carboxyhemoglobin was 46%. In this case, the patient obviously had CO2 poisoning, which was missed because the oxygen saturation was not measured. Is oxygen saturation calculated or measured? Oxygen saturation is measured in a co-oximeter. You should always make sure that the oxygen saturation is measured, not calculated. If it is calculated from the PaO2 and the O2 dissociation curve, it could be inaccurate, especially in states of carbon monoxide intoxication or excess meth-myoglobin. Carbon monoxide and meth-myoglobin do not affect PaO2, but do lower the oxygen saturation. Hypoxemia, low partial pressure of arterial oxygen and/or low arterial oxygen content, is a result of reduced PaO2, usually from lung disease. It can also be reduced oxygen saturation, most commonly from reduced PaO2 from other causes including carbon monoxide poisoning, meth-myoglobinemia, or a rightward shift of the O2 dissociation curve, as well as reduced hemoglobin contents secondary to anemia. Reduced oxygen delivery to the tissues is a result of reduced cardiac output, as seen in shock states or congestive heart failure, as well as left to right systemic shunts. Decreased tissue oxygen uptake is a result of mitochondrial poisoning or left-shifted hemoglobin dissociation curves. How much oxygen is in the blood, and is it adequate for the patient? The answer is based on some oxygen value, but which one? Oxygen saturation and oxygen content are most useful to answer the question. The partial pressure of arterial oxygen reflects only free oxygen molecules dissolved in plasma and not those bound to hemoglobin. PaO2 cannot tell us how much oxygen is in the blood. The percent of all of the available heme binding sites saturated with oxygen is the hemoglobin oxygen saturation. SaO2 alone doesn't reveal how much oxygen is in blood. Only the oxygen content tells us how much oxygen is in the blood. This is because oxygen content is the only value that incorporates the hemoglobin content. Oxygen content can be measured directly or calculated by the oxygen content equation. Here we have the Henderson-Hasselbalch equation, which describes the derivation of pH as a measure of acidity in biological and chemical systems. For teaching purposes, the equation can be shortened to its basic relationships, seen below. pH equals bicarbonate and PaCO2. pH is inversely related to hydrogen ions. A pH change of 1 represents a tenfold change in hydrogen ions. Acidemia is a blood pH less than 7.35. Acidosis is a primary physiologic process that occurring alone tends to cause acidemia. Alkalemia, blood pH greater than 7.45. Alkalosis is a primary physiologic process that occurring alone tends to cause alkalemia. Primary acid-base disorders. They are one of 4 acid-base disturbances that manifest by an initial change in bicarbonate or PaCO2. If the bicarbonate changes first, the disorder is either metabolic acidosis or metabolic alkalosis. If the PaCO2 changes first, the problem is either respiratory alkalosis or respiratory acidosis. Compensation occurs when the change in bicarb or the PaCO2 results from a primary event. Compensatory changes are not classified by the terms used for the 4 primary acid-base disturbances. Respiratory alkalosis is a primary disorder with a lowering of PaCO2 resulting in an elevated pH. Compensation is a secondary lowering of bicarbonate by the kidneys. Respiratory acidosis is a primary disorder where the first change is an elevation in PaCO2 resulting in decreased pH. Compensation is a secondary retention of bicarbonate by the kidneys. Metabolic acidosis is a primary where the first change is a lowering of bicarbonate resulting in decreased pH. Compensation is a secondary hyperventilation. Metabolic alkalosis is a primary acid-base disorder where the first change is an elevation in bicarbonate resulting in increased pH. Compensation is a secondary hypoventilation. Compensation for this metabolic disorder is less predictable than for the other 3 acid-base disorders. Metabolic acidosis is conveniently divided into elevated and normal anion gap acidosis. The anion gap is calculated by sodium minus chloride plus CO2. CO2 is the total CO2 measured as part of a routine serum electrolyte panel and consists mostly of bicarbonate. Normal anion gaps are typically 12 plus or minus 4 milliequivalents per liter. If the anion gap is calculated using potassium, the normal anion gap is 16 plus or minus 4 milliequivalents per liter. Normal values for anion gaps may vary among labs.